Our ASH 2015 coverage continues. I'm Thomas Baldwick, joined now by Dr. Sekeres, a very familiar face here at ASH. Thanks for joining us.
Thanks so much for having me.
How has your conference been?
Busy would be an understatement, but it's been really exciting. Great research being presented here in myelodysplastic syndromes and acute leukemia. Some things that are going to change practice. That doesn't happen every year. So I'm enjoying it immensely.
That has been the theme. People very impressed with the data presented here.
Yeah.
Let's talk about yours. You've got a phase 2 study, a combination of azacitidine. What was that about?
So this is the largest clinical trial that's ever been conducted in North America in myelodysplastic syndromes. What we did is we examined patients who had higher risk myelodysplastic syndrome, and we randomized them to one of three treatments. The first treatment was the drug azacitidine. This is considered the standard first-line therapy in patients who have higher risk MDS. The second treatment was azacitidine combined with the drug lenalidomide, and this is based on phase 2 data that showed high response rates for the combination. And the third arm was azacitidine and Vorinostat. Vorinostat is a histone deacetylase inhibitor, which also showed very high response rates for the combination in earlier phase studies. We then powered this study to look at overall response rate, and we enrolled a total of 277 patients in approximately 2 years. So it was a very rapidly accruing study within the United States and Canada.
So big study, aggressive plans. What was your goal?
So our goal was to see whether or not we could improve overall response rate for one of the combination arms versus the azacitidine monotherapy.
And what did you find?
Well, what we found is that although numerically we improved the overall response rate for patients who received azacitidine and lenalidomide with an overall response rate of 49% versus 38% for azacitidine alone, it didn't reach statistical significance with a p-value of 0.16. We did find, however, that in the subgroup of patients who had chronic myelomonocytic leukemia, this is, although it's called leukemia, it's an overlap of myelodysplastic syndromes and myeloproliferative neoplasms, we had a significantly higher response rate for azacitidine and lenalidomide, with a response rate that was almost 40% higher than the response rate for azacitidine monotherapy.
So what does that tell you?
Well, what it tells us is we need to define our subgroups carefully. Myelodysplastic syndromes are a heterogeneous collection of disorders. If we focus on subgroups, we're probably going to get more bang for our buck with combination therapies than we do with a single therapy.
So where will you go next?
Well, it's an interesting question, actually. One of the things we have to decide is whether combination therapies can be given in a broad general setting the way they have, or whether single institutions with a particular expertise in myelodysplastic syndrome are better suited to giving these combinations. And the reason is that we saw significantly higher rates of dose reduction that weren't specified by the protocol for the combinations versus the azacitidine monotherapy. Clearly, docs were very comfortable giving the azacitidine as a single drug, probably not as comfortable giving the combination.
Always a pleasure, sir.
Likewise.
Thanks for your time.
Thanks so much for inviting me.
You got it.